Okay. Hello, everyone. My name is Dr. Keela Rashid, and I welcome you all on this webinar. On the page of Pakistan Endocrine Society, I am honored to introduce my speakers to have a meticulous talk on a very important topic. I'm honored to introduce my first speaker, who is Dr. Uneeba Syed. She is working as assistant professor endocrinology in Jinnah Hospital, and she has a great contribution in Pakistan Endocrine Society, as well as she has a lot of research work as well. So I welcome Dr. Uneeba. Please start with the topic of thyroid nodule.
Thank you so much, Dr. Keela, for very nice introduction. And I'm sure that the session that PES has actually arranged for our own people, it'll be giving something from the talks that me and of course Dr. Ibrar will be given. I'll try my best to make it short, concise, and I'll try my best that somebody should, have something to take home. So give me a minute so I can just share my slides. And you let me know if you can see my slides. Yeah,
Yes.
right. Okay, so approach to thyroid nodule. So thyroid nodule is very important, and it's very, very prevalent throughout, not just the country, throughout the world. And somehow, whenever thyroid nodule is there, the first thing that comes into mind is cancer to nahi ho gaya. Ab kya hoga? It comes with a lot of anxious things, and sometimes it is so mal handled and not approached with so much cautious that instead of um, giving a logical approach and logical way to treat it, what happens is that it gives a lot of unnecessary anxiety and depression and stress to the patient, as well as sometimes the doctors, they do get into a little bit of trouble how to go about it. So let's just see approach to thyroid nodule, how we go about. So when you say thyroid nodule, it's a discrete lesion, okay, within the thyroid gland that is on palpation or radiologically distinct from surrounding thyroid parenchyma. So you can actually figure out that this is thyroid parenchyma and this is the nodule that we are feeling. Now it can be one nodule, it can be multiple nodule, and I'm sure that each one of us has have patient like that. So when you look at the prevalence, palpable nodules that you can actually palpate is 5% in women and 1% in men. And even if it is incidentaloma, this is more in females. And when you get it on ultrasonography, it is estimated to be 20 to 76% in adult population. And I'll tell you that it's not just ultrasound that has, that gets incidental thyroid nodules. You know, it can be in CT or MRI. It can be on PET scans as well, even MIBG. So any scan that is done can pick up ultrasonography, can pick up the nodule, because for the last few, maybe years or decades, you would say the investigations have become so vast and so advanced that you just pick up a nodule if it's there. And incidence of malignancy amongst the nodule is approximately 5%. However, there are studies which have suggested that it may be as high as 15. So it really, really depends upon how is the nodule, where is the nodule, what are the ultrasonographic features of the nodules, what are the the risk factors in the patient. So the incidence of malignancy, it depends upon so many things. We will discuss these. And this can be presented as noted by the patient. Usko khud hi pata chal jata hai there's something there, or the relatives or the peer. It can be doctor during examination who can just look. And with me this has happened. I would be talking to a patient and I look at the attendance, like there is something there, and when I examine, so that turns out to be a thyroid nodule. So this is very common. And it might be that you are working for a thyroid status for any other condition like infertility or any other weight loss or weight gain or whatever, and you find out a nodule. And when incidentally noted during a radiological procedure such as carotid ultrasonography, CT, MRI, or PET scan, it is then called an incidentaloma. Lots and lots of causes are there. There can be benign causes. There can be malignant. Benign is multinodular goiter, very common. Hashimoto's, it can be cyst, follicular adenomas, Hurther cell adenomas, and then malignant, obviously, something sinister with papillary carcinoma, follicular carcinoma, medullary, anaplastic, even lymphoma and metastatic carcinoma from the breast and renal cell can be there. Okay, so what do you do about it? you have a thyroid nodule, you first go for history and examination. So for the history, पूछना क्या है? Age is very important. The older the person, more nodules will be there, but the younger the person, more risk of malignancy is there. And gender is important because it is more common in females. So history of head and neck irradiation, it's very important because in that case, you have to, you just have another risk factor for thyroid carcinoma. Then rate of neck mass growth, if there is anterior neck pain, there is hoarseness of voice, dysphonia, dysphagia, dyspnea, any of these these are not a good sign. So symptoms of hyperthyroidism or hypothyroidism, very important. This actually changes how you are, going to pursue your further investigations. Then use of iodine containing drugs or supplements, and the other drugs like, amidrone, this is very important, a drug that you must know. Then personal or family history of thyroid cancer or thyroid disease, especially the medullary carcinoma, that is very important that you ask. Coming on to the physical examination, you look for the thyroid sign, you look for the consistency, you look for the location, consistency, size, and number of nodules. This is all what we have actually, learned in third year MBBS or something. But then condition of the overlying skin, the nodulation fixation, which actually is a hard sign, which is not a very good sign if you have a nodule fixation to the surrounding tissue. Then neck tenderness or pain. Whenever you have a neck tenderness, it might change a little bit of your diagnosis or the pathway you're taking for the management. And then cervical lymphadenopathy, very, very, very important that you look for cervical lymphadenopathy. You do not just, look for the thyroid and nodule and, miss cervical lymphadenopathy. That is negligence. Okay, so what you do is you go for the TSH. TSH is so important. You have to have those done because you want to see the functionality of the thyroid nodule. Agar to hyperthyroidism hai, TSH will be low, how you would proceed. You will have, you will get the free T3, T4 level, and then you have a thyroid radio uptake scan, and then you can move further. However, if it is normal or high, and then you have the antibodies, the anti-TPO antibodies if TSH is high, and TSH receptor antibodies if you have to go, and then you can get an ultrasound done if you come out with a TSH that is normal or high. Why ultrasound? Because on ultrasound, you have to see these features. Microcalcification, you have to see hypoechoic, increased nodular vascularity, infiltrative margin, and taller than wide on transverse view. So now point is, okay, why these? Because these are the high-risk features for the malignancy. So what I want you to do is just jot them down. The next time you order a thyroid ultrasound, you write these, that I am looking for these, and this. Yeah, you can write this, kindly comment on these features, so your radiologists know that what are you actually looking for. And this is a very nice, pictorial, you can say, classification or whatever, from going from benign to high suspicious given by the ATA. So what happens is that the risk of malignancy increases from benign, which is less than 1%, to high suspicion, which is more than 70 to 90%. So you are actually looking at an ultrasound and you are actually figuring out whether what you have to do, whether you have to tell the patient it's okay, it's just a cyst, it'll be fine, or you have to tell the patient, oh my god, this is not a good sign, you have microcalcification or hypoechoic nodule or irregular margin, all the hard signs that I've already told you. And then we have intermediate suspicious, low suspicious, or very low suspicion, falling in between the benign and high suspicious. And if you can see, the spongiform or partially cystic features, they come in very low suspicion. If there is spongiform nodule, rest assured that it might not be malignant. Okay, when you have a low suspicion with hyper solid but the regular margins are there, or partially cystic is there. With hypoechoic and regular margin, there is a suspicion. There's 10 to 20% chances of malignancy there. But with high suspicion, all the signs that I have already mentioned, they if they are there, high suspicious. And why are these important? Because they will actually tell you what to do about that nodule and how to go further. Now, this is qualitative, and we have this ACR thyroid classification, which is nowadays, very commonly used. This is quantitative. If you look at that, it has 5, portions like composition, echogenicity, shape, margin, and echogenic. So what happened is that they have points. For example, if it is solid, it has 2 points. If it is hypoechoic, it has 2 points. It is taller than white, it has 3 points. So there are 3, it's a punctate echogenic foci, it has 3 points. So, there are points, and they points are making it quantitative. So we, sum them up, and we have 0 point or 2 point, 3 point, 4 to 6 points or 7 points, on which we decide what to do with the patient. Like if it is 0 point, you call it benign, TR1, TR2 is non-suspicious, TR3 is mildly suspicious, TR4 moderately, and TR5 is highly suspicious. And based on this suspicious trait of that nodule, what you do is you decide whether you want to go for an centimeter. For intermediate suspicion and high suspicion, it is more than equal to 1 centimeter that you have to go for the FNAC. For thyroid, you see TR1 and 2, no FNA required. For 3, you do FNAC if it is more than equal to 2.5 centimeter. If it is more than equal to 1.5 centimeter in TR4, with TR5, as in ATA highly suspicious, it is more than 1 centimeter, you go for FNAC straight away. After that, you see what is the result of FNAC, and your result based upon the Bethesda classification, which I'm actually showing you here. If it comes out to be non-diagnostic, non-diagnostic still has 5 to 10% chance of carcinoma, because the operator might have missed it. So what you do is you either repeat the fine needle aspiration, and you do it ultrasound guided. If the ultrasound had initially high risk features and the FNAC come out to be non-diagnostic, you do that repeat FNAC within 1 year, okay? If it comes out to be benign, so benign essentially has 0 to 3% of carcinoma risk. We are not that much, scared of it. So what you can do is you see if the previous ultrasound was okay-ish and was not showing any hard features, you can do the ultrasound follow-up until there are 2 negatives. If 2 negatives are there, then you can, just leave the patient be, it's okay. With the suspicious for malignancy and malignant, you have to go for surgery. Mostly you go for total thyroidectomy when the size of the nodule is more than 4 centimeter. If it is less than 1.5 centimeter, you go for lobectomy. And between 1.5 and 4, it's about the surgeon's decision. However, mostly go for the total thyroidectomy, because whenever malignancy is involved, nobody's wants to take a risk. The point comes when there is ATP of undetermined significance, that is Bethesda 3, and Bethesda 4, that is follicular neoplasm or suspicion for follicular neoplasm. What happens is you either repeat the FNA in 3, and the two things are you either do the molecular testing or the lobectomy of the patient. So molecular testing, although I'm not sure if it is available in our country, I don't think so we have that, but lobectomy is there. So what molecular testing is, we do, there is most common molecular testing that are used. It is mutational analysis or gene expression analysis. So what mutational analysis does is, it is a rule-in test. This means you isolate DNA from a thyroid follicular cell and perform gene sequencing. And if you find a mutation, for example, BRAF mutation is found, it will rule in the presence of papillary thyroid cancer. So this is mutational analysis is the rule-in test. Just remember that this is same as RAS mutation for papillary and follicular carcinoma, and RET PTC, which we already know. So then you have gene expression analysis or gene classifier. It uses proprietary algorithms with 142 gene panels, and it is designed to identify nodules that do not require surgery. So you will identify that this nodule will not require surgery, so you save your patient from an unnecessary surgery. And then we have microRNA analysis, which is the more recent method for molecular testing. Limited data is available, however, over this, and we here in our country, I think we'll take quite a few years, to reach there. I'll sum it up. Like, if you have a suspected thyroid nodule, you look for TSH first. TSH, See signs and symptoms, see TSH. If it is hyperthyroidism or hypothyroidism, for hypothyroidism, you have to go for the antibodies, anti-TPO antibodies. You have to go for ultrasound as well. If it is hyperthyroidism, along with T3, T4 levels, you have to go for uptake scan, so you know whether it is a toxic adenoma or it is multinodular goiter, or it is just thyroiditis that is presenting in as a hyper. So that is another limb, and this is how they are taken. And I think Dr. Ibrar will be discussing the hyperthyroidism. Hypothyroidism was discussed in the previous webinar that we had. So then what you do is you go for thyroid sonography and see if it was benign, very low suspicion, intermediate suspicion, or high suspicion. And based on that, you go for FNAC according to the size. With benign, I told you FNA not required. With very low, more than equal to 2 centimeter, low suspicion more than equal to 1.5, and more than equal to 1 centimeter when it is intermediate suspicious or high suspicious. जब FNA करवा लिया है, उसका रिजल्ट आएगा. रिजल्ट को आप देखेंगे ऑन द बेसिस ऑफ Bethesda कैटेगरी. फॉर Bethesda, if it is non-diagnostic, benign, AUS, FLUS, FN, suspicious or malignant. Suspicious, malignant, surgery. Non-diagnostic, repeat. Benign, follow-up. जो सेंटर के दो हैं, as we have discussed, it's lobectomy or molecular testing. Molecular testing, if not available, lobectomy is there. So this is how you go about, this is how you approach any patient that has thyroid nodule. So top of the list is history examination. You have to do that. Then you have to look for the functionality, and then this is what you need to follow, and you will exactly reach where you need to reach. And I think that's it for my side. Thank you so much. Back to you, Dr. Keela, back to you.
Thank you, Dr. Uneeba, for a wonderful discussion. Do you have any questions from the audience?
Dr. Keela, I think we can take the next talk, and if there is a question, I will just answer it at the end.
Okay, right. Thank you very much for your wonderful presentation. Now I will be honored to invite Dr. Ibrar Ahmed for next presentation on hyperthyroidism. Dr. Ibrar is head of department in diabetes, endocrinology, and metabolic disorders. And he is also ex-president Pakistan Endocrine Society. Dr. Ibrar, please, over to you.
Thank you, Dr. Gita. ये share screen. ये
Okay, Dr. Ibrar is trying to share the screen.
अच्छा, 1 मिनट में कोशिश कर रहा हूँ.
Yes, sir.
Sir, we can share the screen from here as well if you want.
हाँ, शेयर कर लें बच्चे ज़रा. तो
Okay, sir.
Okay.
अच्छा, सबसे बड़ी बात, थैंक यू डॉक्टर नीबा एंड थैंक यू PS फॉर दिस इंटरेक्टिव वेबिनार्स. मेरी आवाज आ रही है आपको? थोड़ा सा डिस्टरबेंस होगी, लेकिन मैं ट्रैवलिंग कर रहा हूँ तो इसमें कुछ थोड़ा सा प्रॉब्लम होगा. So to start with this important topic of it is one of the most common things after diabetes which we come across in our clinics. So if the next slide, which is Anas.
Sorry, sir, there was a disconnect. Should I move to the next slide?
Okay, thank you. Basically, hyperthyroidism definition is what's because it is usually defined as a syndrome with excess thyroid hormones. But we can come across two terms, hyperthyroidism or thyrotoxicosis. We have to understand these two things. We usually tell our patient that either they are suffering from hyperthyroidism or thyrotoxicosis. So it is because both meanings are the same. But if you get in the depth of it, you come across that there is slight difference between it. Next slide. If you look at a thyrotoxicosis, it refers to a clinical syndrome of hypermetabolism and hyperactivity, which results from excessive thyroid hormone irrespective of etiology. It can't be due to the thyroid gland. If it is a sustained increase in thyroid hormones biosynthesis and secretion, it is only by thyroid gland, it is being named as hyperthyroidism. So in other case, there is irrespective of etiology, and here it is due to thyroid gland. Next slide. Usual presentation, you come across a patient, a female, to your clinic with generalized fatigue and weakness, history of weight gain, constipation, and cold intolerance. A lab shows TSH of 10. The diagnosis at once came in your mind, it is hypothyroidism. But if another presentation, which is most common, next slide. Yes, next slide.
Anchit, if you're there, please change the slide for Dr. Ibrar.
I'm sorry, I disconnected. Are the slides visible now?
Next slide.
Yeah, slides are visible. Next slide, please. He needs you to change the slide.
A young girl came to clinic with palpitations, heat intolerance, diarrhea, and weight loss. But his TSH is low. So the thing is that she might be having hypothyroidism. So here the story begins of hyperthyroidism. The usual presentation is that there may be palpitations, weight loss, or diarrhea, heat intolerance. So TSH is low. So how will you proceed further in that case? We have a bit differences with some physicians, with some GPs, that you should approach your patients step by step. Next slide. If you look at the causes, the things come in that she might be having Graves' disease, toxic MNNG, or subacute thyroiditis, toxic single adenoma, pituitary tumors, molar pregnancies, or choriocarcinomas, metastatic thyroid cancers, stroma ovariae, or thyrotoxicosis fictitia. Next slide. But the most common are usually diffuse, MNGs, toxic adenomas, or thyroiditis. These four things are the most common one. If you look at the symptoms, increased levels of thyroid hormones in blood, T4, T3, and TSH is low. So if it is increased, your things will be speed up, like in diarrhea, sweating and hair growth, nail growth, ankylosis, anxiety, nervous system irritability, insomnia, tremors, tachycardia, palpitation, everything get fast. Weight loss, increased appetite, increased body temperature, heat intolerance, and sensitivity to heat. So everything is fast, it is hyper. Next slide. So the presentation are younger patients tend to exhibit sympathetic activation, that anxiety, hyperactivity, tremors. Older patients usually came from cardiovascular symptoms, like usually patient coming to you with atrial fibrillation, unexplained weight loss, and dyspnea. If an older patient usually come with unexplained weight loss, and he had, if you look at his papers, it will be load of papers which will be showing that he or she might be having some multivitamins. And a simple test of thyroid, if you do it in that cases, you will make the life easier of these patients. Next slide. So precipitating and predisposing factor. There may be genetic susceptibility, infections, stress. Next. Gender, it is most common in women. Smoking, its risk is increased. Pregnancies, drugs, and many more. Next. These are the usual presentations of MNGs or diffuse toxic goiter. In diffuse, there will be small bulge in front of the neck, and in MNGs, there will be a multinodular type of thing. Next. This is dermopathy or thyroid acropathy. These patients usually present with that. Next. So investigations. Next step is an investigation. If TSH normal values is 0.4 to 4, FT4 is 11.5 to 22.7 picomoles, FT3 is 3.5 to 6.5. These are normal values. You should know about it. Keep these things in your mind. If these things touches near to that values, you should proceed further accordingly. Next. So if a TSH is low, then low is hyperthyroid. If it is normal, euthyroid, and high is hypo. So the next step is do the free T4. Free T4 will be high or normal in hyperthyroid. And the same case with the hypo. It may be low or normal in hypo, and high or normal in hyper. Next. The term is overt hyperthyroidism. You will detect an undetectable TSH with raised free T4 or free T3, and its ratio is more than 0.3. You will label them as overt hyperthyroidism. Next. Subclinical hyper is a low TSH and with a normal FT4 and FT3. Next. For if at that moment after a blood test, you start thinking of how should I move further. So before moving further, you have to establish the cause of hyperthyroidism. You either may do TRAP, thyroid scan, or thyroid ultrasound. These are the three major investigations in which you can establish the cause of hyperthyroidism. Next. If you look, it is a quite busy, I have downloaded from the up-to-date. Does the patients have all the following, like new onset orbitopathy, large non-nodular thyroid, moderate to severe hyperthyroid? If these are present, you will label them as a grave disease. If these are not, to look at just examine the thyroid gland. It is nodular or not nodular. If it is nodular, you will go for thyroid scan. If it is high uptake scan, then the things will be much more clear, like Graves, toxic multinodular or toxic adenoma. If it is low, then subacute thyroiditis may be the answer. And if does the patient have a nodular goiter? If it is not present, then you may get the trap. If antibodies are negative, you will go for radioactive scan. Then the module is the same. If the patient is antibodies positive, then the Graves disease is the answer. Next slide. These are the usual pictures of multinodular, diffuse uptake, and toxic adenoma. So on the basis of that, you should have these pictures on technetium or I23, 123 scans. These pictures will be, you will commonly found. Next. So treatment option. From treatment option, you should look at the symptom relief or anti-thyroid drugs, radioactive iodine therapy, thyroidectomy, or NSAIDs and steroids if the patient is having subacute thyroiditis. Next slide. Symptom relief is rehydration, beta blockers to decrease sympathetic excess, rate limiting calcium channel blockers if beta blockers are contraindicated, and treatment of heart failure or arrhythmias. Next. Medical treatment. You will start the medical treatment in those patients where there is a likelihood of remission. For example, female with mild disease, small goiter, negative or low titer trap. There is an increased surgical risk with in elderly or those with other comorbidities like heart failure, or patient may be suffering from any other disease, unable to follow the radiation guidelines, like in patient is in nursing homes or other care facilities, or previously operated or irradiated necks, lack access to high volume, a good thyroid surgeon is not accessible, or moderate to severe active eye disease. These are the indications, like female with mild disease, increased surgical risk, radiation guidelines are not followed, previously operated, lack of access to a good thyroid surgeon, or moderate to severe active eye disease. Next. An indefinite or contraindication to long-term therapy is that previously major adverse reaction to anti-thyroid drugs, or baseline neutral factor is less than 500, or elevated liver enzymes, more than 5-fold of upper level. These are a proper contraindication. Whenever you start the patient on anti-thyroid, kindly do the CBC or LFTs in these patients. Next. So goals of treatment. The euthyroid state should be achievable in 3 to 8 weeks and then taper to maintenance dose. Treatment is usually 12 to 18 months previously, then tapered accordingly to normal. You may continue with the more prolonged treatment nowadays. Choice of drugs is methimazole or profile thyroxine, usually in first trimester of pregnancy. Dosage is a mild hyperthyroidism or small goiter. Methimazole is 10 milligram per day, or moderate to severe hyperglycemia, like you have a large goiter more than 300 milligram, 20-30, or carbimazole 45 to 60 milligram, or profile thyroid 150 to 300 milligram. Persistent remissions rate when the drug is discontinued 1 to 2 years later averages about 30%. Usually it doesn't happen, but the remission rate in many studies is 30%. Next. Common side effects, as I've told you, pruritus, rash, urticaria, arthralgias, arthritis, fever, abnormal taste sensations. Rare side effects are severe but uncommon, like agranulocytosis, hepatotoxicity, ANCA positivity, aplasia cutis in fetus. Next. Recommendation for treatment is a differential WBC count should be obtained during febrile illness and at onset. Routine CBC monitoring is not recommended. Patients should be informed of side effects of ATDs and necessity of informing their physicians if they have developed pruritic rash, jaundice, dark urine, arthralgias, abdominal pain, nausea, fatigue, fever, or pharyngitis. Before starting antithyroid drugs at each visit, patient should be alerted to stop the medication immediately and call the physicians at once. Next. Radioactivity. This is most commonly if indication is females having planning to pregnancy in the future in more than 6 months' time. The contraindication is a pregnancy within 4 to 6 months. Within 4, you shouldn't do radioactivity. Pregnancy and lactation. If the individual is having comorbidities like increased surgical risk, you should start it. Coexisting thyroid cancer or suspicion of thyroid cancer, you shouldn't start with thyroid cancer, RAIs. Previously operated or irradiated. Next, lack of access to high volumes, good surgeon, and contraindication of antithyroid drugs. The contraindication is female planning for pregnancy within 4 to 6 months, pregnancy, lactation, coexisting thyroid cancer, individuals unable to comply with radiation safety guidelines. Next. Primary RAI should be given to patient with mild, well-tolerated hyperthyroidism, pre-treatment with methimazole and beta blockade prior to RAI for Graves is considered extremely symptomatic for FT4 estimated 2 to 3 times more than upper limb. Don't do the RAI at once in patients who are having FT4 2 to 3 times more than upper limb. Made them stabilize with drugs and then do the RAIs. Prerequisite is patient should be advised on radiation safety precautions, optimize medical therapy of comorbid conditions. A pregnancy test should be obtained within 48 hours. Discontinue methimazole 3 to 5 days before RAI administration. Restart 3 to 7 days later. Taper over 4 to 6 weeks as thyroid functions normalizes. Usually we stop at once the methimazole the day we give them RAI. But do take care of patients that they may have increased secretion of thyroid hormones after RAI. So they must be controlled if the patient is previously on methimazole. Next. Administration is as a capsule or oral solution. It concentrates in thyroid tissues, extensive thyroid tissue damage, ablation of thyroid within 6 to 18 weeks, admission sufficient radiation in single 10 to 15 millicuries. Provide patient with written advice. Follow up this patient 1 to 2 months after RAI for access to for T4, T3. If remain thyroid, continue monitoring for 4 to 6 weeks. Treatment failure, the persistent GD after Graves' disease after 6 months or minimal response after 3 months. Do consider usually we put the patient on 4 to 6 weeks. If they are normal, we usually declare them that they are normal. They can continue. They can go and have this normal life without thyroid drugs. So usually they come to us with symptoms of thyrotoxicosis or symptoms of hypothyroidism. Do follow a patient at least to 6 months. Next. Surgical treatment is severe hypothyroidism in children, pregnant women who can't tolerate ATT, larger guiders with severe ophthalmopathy, large MNGs with pressure symptoms who require quick normalization of thyroid. This fifth one, I didn't agree. We should consider options, pros and cons, and do tell your patients about that you have this option till end in your hand. Large MNG with pressure symptom is very common. You do consider cardiothoracic surgeon or a good ENT surgeon who can go. Usually, ENT surgeons usually are approached to neck. They didn't go below the in the chest. So do consult a cardiothoracic opinion in patient with having pressure symptoms. And whenever you have a patient with pressure symptom, do consider surgical treatment as a first line treatment. Next. Indication is symptomatic compression, thyroid malignancies, thyroid nodules, coexisting hyperparathyroidism may require surgery, moderate to severe active disease, relative low RAI. Contraindication is comorbidities like cardiopulmonary disease, pregnancies. It is a relative contraindication. Do if rapid on control of hyperthyroidism required and HET cannot be used. Best time later half of second trimester. Next. So it is one of my last slide. It's regarding management. Medical treatment to control the symptoms first of all, and then control of hyperthyroidism with these 2-3 drugs. Do consider agranulocytosis, renal liver function tests before starting, and whenever you come across a patient who is on carbimazole with different rash or having some yellowish discoloration of sclera, or there may be some abnormality in urine, do consider to stopping it and consider other modalities. Remission of Graves' disease is 50% after 6 to 18 months of treatment. Radioactive iodine, usually it is integrated with toxic MNG, Graves' disease. The caution in pregnancy, thyroid eye disease, incontinence, breastfeeding. Outcome, it is 90%. 90% is much higher figure, but at least 70% after first dose. Surgery, contraindication to medical therapy, relapse, GD or thyroid eye disease. Caution is large laryngeal nerve palsies. Do consider outcome of hypothyroidism and possible hypocalcemia. Next slide. Thanks for hearing me. आप पीछे background में आवाज भी सुन रहे हैं, लेकिन was must on me. So with that, thanks for patient learning. कुछ sounds आपको distract किए होंगे. It is very simple. I put it very simple. And thank you, Uneeba, and thank you. Yes.
Thank you, Dr. Ibrar.
इसमें ये क्या मैं लीव कर गया किसी टाइम में, तो फिर डॉक्टर नीबा है क्वेश्चन आंसर्स का होगा.
Yes, sir. I'm here. I'm here. I think
Thank you, Dr. Ibrar. It was a wonderful presentation.
You
Yes,
have a few
there were,
questions here. Yeah.
yes, Dr. Ibrar, please answer that.
Yeah, I can see one question which is regarding radioiodine scan, and I think Dr. Ibrar has already answered it, or this might be pertaining to Dr. Ibrar's talk. However, there is a question by Dr. Suhail Ahmed that any specific treatment for asymptomatic small thyroid nodules. So my point is that I've actually discussed this, that it depends upon how small is the thyroid nodule and what was the ultrasound, the features, whether there were highly suspicious features like I have mentioned, like micro calcifications, or irregular margin, or taller than wide, any of that feature is there, then symptomatic or asymptomatic, whatever it is, especially the asymptomatic which you are asking, if they have ultrasound findings that are high risk, you have to go for FNA as per the ATA or ACR tyrate, and then you move forward as Bethesda category. This is exactly what I was trying to tell you, how to proceed with these nodules. I hope this answer you. It does not, the whole flow chart that I tried to explain was for the asymptomatic thyroid nodules, or if you say euthyroid, if I may say, if TSH is normal or sometimes high, because when TSH is low, the risk of malignancy, I think Dr. Ibrar and Dr. Aisha would agree to me, the risk of malignancy in TSH when it is low, it also drops down. So when it is asymptomatic, or in other words, if TSH is normal or a little higher, then you have to follow all the algos as per ultrasound findings, and then further the FNA if required, and after the FNA you have to move as I discussed. Okay, then
Uh,
can
another,
ESR give?
hmm.
Yeah. Yes, Akila?
There is a question about ESR. Can it help in etiology of hyperthyroidism?
I think if Dr. Ibrar online?
Dr. Ibrar, are you there? Sir, are you there?
Okay, if I may, Dr. Akila, if the ESR give clue to etiology of hyperthyroidism, if the something that actually gives you the clue about etiology of hyperthyroidism is radio iodine uptake scan. However, ESR can show you can tell you if you are heading towards a thyroiditis, which is more of an viral origin or something.
Inflammatory. The next
Yeah.
question is about subclinical hyperthyroidism.
Okay.
If patient has symptoms of
Patient has symptoms
hyperthyroid,
of TSH is in low limit. Okay, so subclinical hyperthyroidism. See, it's when not every
but
subclinical hyperthyroidism needs to be treated. If there has to be a few conditions. For example, if it is less than 0.01, along with symptoms, along with cardiac, if there are cardiac events or cardiac symptoms are there, if the patient's age is if it's a young patient, or patient has afibrillation pertaining to that, or heart failure pertaining to that, and even osteoporosis if patient is having and has subclinical hyperthyroidism, all of these, then they need to be treated. However, if not, it's just that mild subclinical hyperthyroidism is there, just a little drop in TSH, then that needs to be just followed up.
thank you. Is there any other question? Yes, we have one more
A
question.
patient, yeah. Can you
Patient has thyroid nodule with subclinical hyperthyroidism and compressive symptoms. What should be best course of action?
right. So you have a now this is very interesting question. If a patient, there is a thyroid nodule and there are compressive symptoms. So when compressive symptoms are there, this is a hard sign that you have to proceed for surgery, but not just like that. You cannot just go and say, Acha, go for surgery. You have to see what are the ultrasound findings. You have to look for the FNSC, what exactly is, because which type of malignancy is there, if it is a malignancy, or is it not a malignant condition, just compressive symptom because of the weight. Because if thyroid is more than 80 grams, nodule more than 4 centimeter, or thyroid more than 80 grams, it is surgery straight away. With compressive symptoms, it is surgery. And subclinical hyperthyroidism, now it depends how much subclinical is it, because sometimes with subclinical hyperthyroidism you can actually proceed to surgery. Now the important thing is you have to get a CT scan of the patient. If you are actually if you have malignancy in your mind, you have to go for a CT scan, look for the extension and the lymph node involvements as well, because the type of malignancy, if it is malignancy and not just the weight of thyroid that is putting the compression, then you have to know which type of malignancy is there, because of the radioactive radiation that might follow the
Surgery.
the surgery.
Yeah. And the extent of surgery as well.
Yeah, of course. More or less, whenever malignancy, you have a malignancy to deal with, it's more or less total thyroidectomy with neck dissection, level 4 up to level 6, if lymph nodes are involved to that level.
Okay. And there is
Okay,
one more
I think
question.
we have enough. Yeah.
Yeah. Subclinical hypothyroidism in patient with infertility.
Okay, so subclinical hypothyroidism. Now, as subclinical hyperthyroidism have indications of treatment, subclinical hypothyroidism have indications of treatment. So first and foremost, if TSH crosses 10, you treat. Along with that, if it does not cross 10, it is 3, it is 5, it is 6, and it is subclinical hypothyroidism with the patient of infertility, you treat. This is an indication of treatment. Okay, so if the patient, even even if the patient has depression, or patient has menstrual irregularity, or even patient is just symptomatic with subclinical hypothyroidism, you treat that patient. With infertility, absolutely yes.
Thank you, Dr. Uneeba. Do you have any other questions? no more questions. Thank you, Dr. Uneeba, for your wonderful talk and discussion. We are really grateful for your time and commitment.
Thank you so much, Dr. Keela. You have been very nice host. And I think I think Dr. Ibrar probably was unable to, join again. And I really would say that it was very nice of him to join us from the airport. He's flying, he's flying to US for a very important task. And still he was nice enough that he took out time and joined us from there. And I must thank you, Akila. You did a very great job.
Thank you, Dr. Uneeba.
So we call it a day. Thank you, Dr. Aisha, for joining, and thank you, Anas, as well. Okay, ji.
Thank you, Dr. Aisha.
Yes, Dr. Aisha.
Thank you very much, Akila, for wonderful moderation, and thank you, Uneeba, Dr. Ibrar, for really comprehensive and knowledgeable lectures. And thank you, Anas and Harun and Adil, for your guidance.
Thank you, everybody. Allah Hafiz.